Good afternoon, everybody. Actually, the previous speaker was wondering who he's going to offend on the list. I was not even on the list of those who talked. For the next few minutes, I'm going to talk about cardio-renal syndromes. These are my disclosures. And for the sake of the audience, I will obviously concentrate on acute cardio-renal syndrome here. This is our current understanding of the pathophysiology of cardio-renal syndrome. On the outer circle, you see the arterial side, the left side of the circulation, where whatever happens, we have low perfusion of the organs, including the kidney, neurohormonal activation, renal dysfunction, leading to water and sodium retention, congestion, and then worsening cardiac function. On the inner circle, the blue circle, you have what we call high backward pressure now. What we have the congestion of the venous system leading to congestion of the renal veins. You might have heard these days, we call it congestive renal failure. Then we have through some mechanisms, worsening of cardiac function. I have made this slide myself and I published it, but if you ask me, I believe in everything that is written in it, I don't. But this is what has been proposed. So just to make sure I summarize the previous slide, we were talking about low forward flow versus high backward pressure. That are the two main theories of renal dysfunction in heart failure. If you have a patient with heart failure, gets decompensated once in a while, comes to the hospital, we decongest the patient. Next talk would be about how we decongest them. So we will have some endpoints. These are whether clinical or research. There will be fluid removal, weight change, or whatever. Some of these patients will show some degree of increase in serum creatinine. Some of them will get better, but will come back later to the hospital, and some of them, unfortunately, will die. When you look at this slide, you have all the endpoints that you need for clinical and research purposes. That is why renal function, as we say, is one of the safety measures that every trial looks at it. Having said that, the concept is that we have an intervention, it gives us increase in serum creatinine, and that is associated with adverse outcomes. That's why we are interested in it. However, my question would be, it comes with a little bit of a delay, I guess. Okay. If it is validated even. So, several years ago, many studies show that any increase in serum creatinine is associated with worse outcomes. It is not necessarily related to heart failure. If I have cataract surgery, I have increase in serum creatinine, I might have worse outcomes. But in heart failure, it is really pronounced. A few years later, ESCAPE trial came out. Here is what we saw. We saw the baseline creatinine had a major impact on the outcomes. The discharge creatinine also had a great association with the outcomes. But when you look at the change in serum creatinine, when the patient came, you gave him the treatment, it doesn't seem that change in serum creatinine, increase in serum creatinine had anything to do with the outcomes. Dose trial a few years later, high dose versus low dose diuretics. When you look at the high dose, you will see that, yeah, it does a better decongestion compared to low dose, as it is expected. Also, it is associated with too many patients getting a rise in their serum creatinine, yet the outcomes are not changing. Tomorrow, we are going to hear a lot about LVAD. Actually, I wish there was a session on LVAD and the kidney. LVAD and the kidney, they have a very particular relationship. As you see in this diagram, this is GFR, not the creatinine. What you see is that when I give LVAD to a patient, typically the GFR goes up, not time to open champagne. 1 month later, it starts to go back down. If you look at the creatinine, it's the other way around. The creatinine goes down, 1 month after goes up. So what they showed is that, this is the Yale group, UPenn, and they went to Yale. So what they showed is that if you have major improvement in renal function, your outcomes are actually worse. And this is shown in this U-shape curve. Any change in serum creatinine is bad, whether it is improvement or worsening. To broaden actually the scope, if you come out of heart failure and look, this is a meta-analysis a couple of years ago in our best journal of nephrology, JASN. This also showed pretty much the same thing. The intervention that increased the risk of AKI, increase in serum creatinine, yes, at the top you will see, yes, they increased the AKI, but when you come down, mortality did not change. The other way around, if you have an intervention that improves the serum creatinine just a few, 0.3, again, the mortality is not improved. Well, can the era of biomarker be the answer to our problem? The biomarkers are the hype these days. Can they help us? This paper was published a few months ago. So they looked at the different biomarkers of renal injury and our usual serum creatinine and cystatin C. You don't have to go through the details of the diagram. Just by looking at the dots, you see the dispersion. There is no correlation whatsoever between anything with anything. When you look at the worsening renal function specifically, compared to those who did not have worsening renal function, again, you don't see any difference between the biomarkers. It's complete disconnect. Alarming is this one. It tells us, look at the blue line at the bottom. It tells us, if your markers of injury are coming down, or your cystatin C or creatinine is coming down, you are in your worst shape. Your best bet would be if your kidney function gets bad during treatment for congestion. So if you tell me, what should I call it? Is it AKI? Is it worsening renal function? Is it pseudo-AKI? I simply call it rise in serum creatinine, because we really don't know what we are really talking about. It's better to be descriptive rather than finding a specific name for it. What is the explanation? In part, not totally. It might be that we have been missing congestion. If a patient has increase in serum creatinine, but the congestion has been taken care of, then the outcomes are good. This is the paper from Dr. Metra. This is 2012. In 2018, they had a similar paper, but the diagram was not as good, so I used still this one. The same, it has been shown by Testani group a few years before that. If you have increase in serum creatinine and you are congested, you are in worse shape. But if you have increase in serum creatinine, the congestion has been taken care of, you might be doing fine actually. To finish, perfect. That was my take-home message. To finish, take care of congestion. Dr. Jessup once wrote in an editorial, the topic was, and it is again offensive to nephrologists, but I believe in it, they say in acute heart failure, treat the heart, don't mind the kidney. Being a nephrologist, it might be shocking, but this might be what the nephrologist should be thinking of. Thank you very much for your attention.
Excellent talk. Let's open it up, and we have an immediate comment and/or question.
So since it's a shock symposium, I have a question about initiation of CRRT, continuous replacement therapy in shock patients. I think there's always a back and forth in when to start CRRT in these patients. Do we wait until we meet all the indications for acute dialysis, or we should just trigger and just start CRRT when you see a patient when there's lactic acidosis increase and decrease urine output?
Perfect. Well, first of all, you saw that the talks are all about shock. Since I didn't have anything in my talk about the shock, I tried to be very shocking to you. So I hope you have appreciated that part. Your question is actually something that in practice we really encounter quite a bit. And I'm not going to steal from the next speaker because he's going to talk about
Feel free to steal from the next.
Actually, most of my talks and publications are on ultrafiltration in heart failure, mechanical fluid removal in heart failure patients. In those studies, it seems that the earlier you go, the better it would be. There are unload trial, there is avoid heart failure trial, they showed the same thing, and CARES that started late had bad outcomes. In terms of CRRT, actually it goes to the same concept that I was talking about. If you are a big believer that congestion is the main driver of the outcomes, then you're not waiting for potassium to go up. Then you are not waiting for resistant acidosis. You are not waiting for the BUN of whatever are your scenarios. You think, I am not able to take care of congestion of this patient with medical therapy, I start CRRT. I have no problem. And let me extend your question to another specific setting, which is the chronic heart failure. This is not the theme of this symposium, so just make it very short. In patients with chronic congestive heart failure, when you see you are not taking care of the congestion, it's better to start some form of therapy, including peritoneal dialysis, even if the patient is stage 4. He's not ESRD, but you can treat the patient. And I can tell you, I was practicing in France. They are very easily starting a patient with a creatinine of 2 on peritoneal dialysis for heart failure, not for the kidney. Again, congestion is the main culprit.
May I challenge you for one of your points? I mean, you mentioned that the patient who are put on assist devices, whatever else it is, improving their GFR and creatinine levels have the worst outcome. Isn't it just because they begin with the worst kidney function, and so that you are just picking the worst case scenario, where these patients are very poorly perfused on their kidneys, they have very bad kidney function, and of course, just you improve the situation, and you just highlighted these patients as the worst case patients compared to the other one.
This is very true. That's actually one of the explanations why improvement in renal function does not necessarily get associated with better outcomes. The point I think I would make is that we shouldn't have creatininophobia. Whether improvement should not make us super happy or its increase should not be. I think, and I don't say that we should completely dismiss it, but when it comes to just comparing the parameters, it seems that congestion plays a better role.
Yeah, please, David.
So I completely agree with what you said, and you know, we always talk about that congestion and the intracardiac filling pressures that, you know, even in the acute setting, people always go back to dry weight. You know, when you're talking to the nephrologist, somehow it always comes back to that. But there's an expiration date on that, where a dry weight probably is not good for more than 4 to 6 months in an end-stage cardiomyopathy. And nobody ever sat at a funeral and said, well, they died of heart failure, but their kidneys were perfect. That's a win for us.
Very true. Very true.
So, but the other thing, the opposite could be said. Would you care to comment? You kind of alluded to this, but you know there are differences in opinions amongst nephrologists about what is the appropriate GFR or when is the appropriate time to actually start a mechanical therapy. And my understanding is, and tell me if I'm wrong, that the outcomes are actually better if you start some type of dialysis earlier than later.
Are we talking about the chronic or the acute phase?
You know, I don't think we have that data for the acute patients.
Yeah.
I think for the chronic ones we do. But I'm asking your opinion about whether it applies to the acute patients.
Well, for the acute ones, I think it would be better, but I don't know of any study that had a comparison of head-to-head to see early versus late would make any difference. It just does make sense. In the chronic phase, as you probably know, when you start a patient on peritoneal dialysis, the patient, actually we have this study published a few years ago. The patient was spending his time 90 days in the hospital a year before peritoneal dialysis started. That went down to 1 day after starting peritoneal dialysis. It didn't affect their outcomes. The pump is bad, the pump is bad. But look at the quality of life of a patient who is spending 1/4 of his life in the hospital versus somebody who just come for visits.